Good morning, good evening, and greetings all participants. I'm Mohammed Naveed. I am a secretary and PRO at the Global Operating Room Pakistan chapter. I'm excited to be here with you today to present the Operating Room Global from the Pakistan chapter. So, warmly welcome to all respected members. This is our second formal webinar. I want to present short introduction about the TORG, the Operating Room Global. The Operating Room Global is a professional platform for operating rooms and the related allied health staff, all disciplines, both locally and internationally. Like that, surgeons, our physician assistants, anesthesia departments, theaters, preoperative nurses, scrub nurses, and technologists and technicians, etc. And many more departments who is related to operating rooms. Currently, TORG memberships more over the 100,000 operating room professionals. These professionals from over the 70 countries. So about our president and founders, Ms. Adibusla is our founders and president of the Operating Room Global since 2015. She is award-winning team leaders, auditors, certified pre-operative specialist, motivator, and high-skilled career professional with over the 16 years post-registration practical experience in the operating rooms and actual care. She is currently working as a clinical nurse manager. So without wasting the time, I want to hand over the Ms. Sadie for the opening remarks. Over to Ms. Sadie, please.
I want to welcome everyone to this webinar. Thank you so much, Mr. Naveed. Thank you to all our executives in Pakistan chapter. I want to welcome everyone to the first webinar of the year of TORG-Pak chapter. I believe today's webinar is focused on disinfection and sterilization, especially in relation to how to prevent surgical infections. This is a topic that is needed today, that is very relevant to every OR, regardless of your country. I would like to encourage everyone to participate actively, pay attention, ask questions if needed, and if you would like to contribute as well, you can always do that. And I also want to use this medium to inform everyone that we are actually live on YouTube, and everyone will be watching us from all over the world. So thank you so much, everyone. Thank you to everyone for joining the session. Thanks a million.
Thank you so much, ma'am. So now we move forward to our today topic. Our topic is preventing surgical site infection. Basically focus on sterilization and disinfection. Today, our speaker is Mr. Abubaker Khan. He is a very experienced person in operating rooms, and he is a BS honors from the Bell Universities in discipline is OT technologist. BS honors in OT technologist and MS in public health, quality improvement, and patient safety. So I would like to invite Mr. Abubaker Khan. Please, Mr. Abubaker Khan, carry on.
Thank you, Mr. Nabi. Thank you, Ms. Hadi, and welcome all participants here. I am Abubaker Siddiq. Today's my topic is in front of you, preventing surgical site infection and focusing the sterilization and disinfection. Please confirm I'm audible, please.
Everything is perfect. Please share your screen.
Yes, sir.
Thank you.
Please open the file because we cannot see your presentation.
Okay, can you see, please?
Not now.
Is it visible, please?
Your screen is open, sharing. Your presentation is not saying as well. Can you open your presentation, please?
Have opened it, please. Let me check it again.
Share again, please.
Yes, I'm doing it, please. Is it visible?
Yes, yes, okay, it's perfect.
Thank you.
Yes, sir.
Is it still visible?
Yes, it's right. Okay. And please
Thank
close
you.
the sidebar, please.
Okay. Is it okay?
Yes, thank you.
Okay. Let's move to our topic, preventing surgical site infection, focusing on the sterilization and disinfection. As you can see, there are two parts of today's topic, preventing surgical site infection, and second is focus on the sterilization and disinfection. As the time is short, we will inshallah try to complete our both topics. Otherwise, we will stay on our first topic, preventing surgical site infection. Let's move towards our objectives. What is an SSI is our first objective, risk factors of surgical site infection, patient factors towards the surgical site infection, operation factors towards the surgical site infection, and strategies to render or stop or avoid the surgical site infections. What is an SSI? Surgical site infection. According to the CDC guidelines, surgical site infection are post-operative infections that occur at the site of surgery. Surgical site infection can range from the mild to severe and occur at any level. Some only involve the skin, but others can be deep and damage tissue, organs, or implanted materials. Symptoms include the redness and pain, drainage of the cloudy fluid, or blood from your surgical wound, or fever. Let's go ahead. Surgical site infections are associated with an increased mortality rate of 3% and nearly twice the length of stay of patient in the hospital, which could range from 10.56 versus 5.6 days. They are the costliest hospital acquired infections, which is called surgical site infection and nosocomial diseases and etc. With an estimated amount annual price tag of 3.5 to 10 billion in the United States. Surgical site infections. The third most common type of nosocomial infection, accounting for 14% to 16% of all the infections. Among surgical site infections, surgical patients, surgical site infections are the most common nosocomial infections. Observed in 38% of surgical cases, which is two-thirds of these infections are due to incision, whereas one-third are due to the infection of the organs or spaces during the surgery. Let's move toward the patient factors, surgical site infections risk factors. There are multiple contributing factors which can cause the surgical site infections. Few are here: age of the patient, diabetes, nicotine or steroid used, altered immune response, malnutrition or obesity, preoperative colonization with the Staph aureus, prolonged preoperative stay. Let's move toward the second option, which is the contributing factor in the surgical site infection. Operation factors. Surgical site infection risk factors are surgical techniques and surgical drains are the most common risk factor or the contributing factors in the surgical site infection. Or ventilation. You can know there are multiple contributing factors in the ventilation like HEPA filters, their laminar flow, and all these contributing factors are included in the surgical site infection, temperature and humidity also. Inadequate instrument sterilization. During the duration of the surgery and surgical scrub, as you know, there are multiple times we have seen that our first assistants, our physicians, our surgeons mostly compromises the scrub steps, which must not be compromised at any cost. At the end, we have seen the percentage of surgical site infections. Skin antisepsis and body temperatures, preoperative shaving, prophylactic antibiotics. Surgical site infection preventing strategies. Supplemental preoperative measures. Nasal screen and decolonize only Staph aureus carriers undergoing the elective cardiac and other procedures. For example, orthopedic neurosurgery procedures with implants, with preoperative mupirocin therapy. Screen preoperative blood glucose level and maintain tight glucose control post-operative day 1, post-operative day 2. Procedures, for example, arthroplasties, spinal fusions. Surgical site infection prevention strategies, core preoperative measures. Let's move toward the closest point where we are serving is the first point we can implement the check to avoid the surgical site infections. We must check the IPSGs. We must check the below mentioned points. For example, antibiotic starts, selection of antibiotics, timing, administration dose, and redosing. Administer antimicrobial prophylaxis in accordance with evidence-based standards and guidelines. Administer within 1 hour prior to the incision, 2 hours for vancomycin and fluoroquinolones. Select appropriate agents on basis of surgical procedure. Most common surgical site pathogens for the procedures. Published recommendations. Please ensure the instructions of doctors. Guys, are you hearing me? Am I audible?
Yes, yes, perfect. Please carry on.
Thank you, thank you. Surgical site infection prevention strategies. The core preoperative measures remote infectious infections whenever possible. Identify and treat before the elective operation. It means we have to evaluate properly the patient, either it is infected or not, to ensure it would convert into the surgical site infection or currently the patient have comorbidities. Postpone operation until infections has resolved. Do not remove hair at the operative site unless it will interfere with the operation. Do not use razors as they make minimal bruises which could also be the cause of surgical site infections. If necessary, remove by clipping or by use of depilatory agent, which could be creams or chemicals. Let's move toward the summary where we can see there are multiple checks which could avoid the surgical site infections. There are two major points: the drapes and gowns, the operating room disciplines. As per WHO, the World Health Organization, surgical site infection prevention in the primary healthcare setting. First of all, the patient must have preoperative bathing, hair removal if required, surgical hand preparations, and surgical site skin preparations. Preoperative surgical antibiotic prophylaxis is the first part. On the other hand, we can see the environmental cleaning, surgical antibiotic prophylaxis prolongation, decontamination and reprocessing of medical devices, wound dressings. Surgical site infection prevention strategies. The core preoperative measures, skin preparations. As we have seen recently in the previous picture, skin preparation, use the appropriate antiseptic agent and technique for the skin preparations. I hope all of us know very well antiseptic effectively works when we give it exact time and exact quantity, volume of the chemical before incision. Maintain immediate post-operative normothermia as the temperature of patient also contribute in the SSI. Colorectal surgery is patients mechanically prepare the colon, anemias, cathartic agent, administer non-absorbable oral antimicrobial agents in the divided doses on the day before operation. Surgical site infection prevention strategies, the core intraoperative measures. It is the point where many of us can even see at our facilities. Most of our colleagues interfere during the surgery. Many times the door of operation theater opens and closes. Can you please share, can anyone share their experience during the surgery? What are the flaws we are noticing at our facilities? Just to say for example of our experiences to avoid in the future for the surgical site infections. Can anyone please share? Can anyone please?
In my previous organization, they are doing like that. Some are my colleagues interference during the surgery, they open the door and check which is set is available and not like that, and sometime check the checklist, etc.
Yes.
So that's why we prevent this issue. We did take the action. We are means we did provide the every professional who is working in OR in daily basis we
Yes.
are giving the some means like that options that staff
Yes.
is going to access the OT. just
Yes.
who is working in our OR. So would it take to resolve the issue when this is the all professionals thinking and they adopt this policy, then no need for this one, I think so. So we did stop these practices after their practices is utilized, everything is understand about this one.
Yeah. Thank you so much, Mr. Naveed. Can anyone please also can share their insights? What checks should be implemented to avoid this contributing factor in the surgical site infection? Which could be the checks to render to prohibit this practice to get save our patients from surgical site infections? Anyone, please?
Hello,
Yes.
can you hear me?
Yeah, yeah, sure.
I think there are instances where we have students in training. Sometimes the checklist has been taken before the entrance to the operating suite. Sometimes some students are fond of coming late. So there should be a policy that prohibits anyone coming into the suite immediately there is a knife on skin. I think that will help a lot.
Yeah, policies uh, can play a maximum role, but practically our colleagues and we ourselves breaches these rules. What should be the step which could prohibit this practice?
Okay, I think maybe looking at the nature of the operating room or the suite per se. Now, when you take a close view, those some most are flip doors like that. Once you open and close because a student is coming in to join the team. So policy number one, I think there should be the use of screen. Once there is a extended screens to cast a view to the students that are already late instead of allowing them to join the surgery while in session. So I think a cut method will help a lot.
Yes, thank you so much, Mr. Abhishek Timothy. Thank you. Anyone else, please? Let's move toward the next slide. The surgical site infection prevention strategy core intraoperative measures. Operating room OR traffic. Keep OR door closed during the surgery except as needed for the passage of equipment, personnel, and the patient. Here I have a question. Why there is a need to go our circulator again and again outside the OR? Can we make a strategy to render this practice so that our circulator should not go outside of the OR intraoperatively? Anyone can please give their insights?
Well, from my point of view, let me just say something. I know it's very common, even in Ireland, it's common. I mean, it depends on the specialty as well, especially when it's orthopedics. You discover that there could be a lot of traffic from reps running to get implants because sometimes if it's a revision procedure, if it's spines, if it's neuro, if it's complex procedure, things might change even halfway through the case, and then you discover that despite the fact that the circulators made all the efforts to get everything on the preference cards, things might still change. You might end up opening like 5 more trays, 10 more trays, and you see people running to get supplies and stuff. I think if we want to eradicate that practice, a committee should actually be developed into looking at how to reduce infection control practices, how to improve that in the operating room environment. And as much as possible, it's the responsibility of the scrub nurse or the surgical technologist to anticipate any change in the procedure. A laparoscopic procedure, for example, if it's minimally invasive, if it's robotics, it could be converted to open. So those things that might serve as that could serve as a reason for people in the room to have to run out should actually be in the room or in an adjunct room. That they wouldn't have to open doors excessively. And sometimes for infection control practices as well, the number of the students or the number of professionals in the room might actually be reduced to ensure that the traffic is minimized as much as possible. I believe it's a teamwork. It's a teamwork and it needs to be reviewed constantly, the practice in every OR. Thank you so much, Mr. Khan.
Thank you, Ms. Eddie. Here I have another question. Do we know about the dust particle one person carries when enters in the OR? Anyone, please?
Sorry, can you come again with the question?
Yeah, my question was, do we know how much dust particles a person carries with himself when he or she enters in the OR?
Oh, don't think.
I think we might need to do a research into that
Distortion
unless the
in your voice,
values
please.
and
Repeat again, please. Your voice was distorted.
Oh, okay. I was saying, I think we might need an evidence-based research on that. For me personally, I don't think I have an idea on the amount of dust particles that someone will actually carry into the OR. If there is research, yeah, you can share, please. Thank you.
Yeah, thank you. About 2.5 to 3 lakhs dust particles one person carries when enters in the OR. Think how much he or she can make a disaster inside the OR in a invasive procedure. Can we imagine, please? Let's move toward the next slide, please. Surgical site infection prevention strategies, supplemental preoperative measures. The nasal screen and decolonize only Staph aureus carriers undergoing. I think I have covered this slide already. Move toward the next slide. Surgical site infection prevention post-operative measures, surgical wound dressings. Protect the primary closure incisions and sterile dressing for 24 to 48 hours post-op. There is another debate that we compromises at the end of the surgery when we have done very well in a multiple hours surgery, but at the end we compromises at the end of surgery when we are going to dress up the wound. At last, it results in the surgical site infections. Control blood glucose level during the immediate post-operative period, like cardiac surgery. Measure the blood glucose level at 6 a.m. on post-operative day 1 and post-operative day 2 with procedure day post-operative day 0. Maintain post-operative blood glucose level at least less than 200. Discontinue antibiotics within 24 hours after surgery and time 48 hours for cardiac. Surgical site infections prevention strategies. Supplemental preoperative measures. It is again coming. That's surgical site infection prevention supplement. The last question should we take the feedback of surgeons, specific infection control rates? Should we take the feedback? Anyone, please? Let's move towards. The second part was the focus on sterilization and disinfection regarding the surgical site infection. As we know, CSSD and surgical site infections connected with each other, while anytime where there is a patient came infected, and first impression regarding the infected patient goes that this is due to the malpractice in the CSSD. Am I right?
Yes, every time they are blaming on CSST if any surgical site infections occur.
Exactly. This
Yes, sir.
is
I agree.
this is the only fault of CSSD. Even there are multiple co-factors related to the surgeons, related to the first assistant, related to the scrub person, but no one focus at them. Why? Because there is a no designation inside the OR who focuses on the practices of surgeons, focuses on the practices of first assistants, who report on these practices so that the data comes out to correct these lackings. Anyone can please share their insights so that we could also learn their insights, please. This is the last slide, I think. Thank you, everyone. And now I would like to get your insights.
Uh, Sir, I want to talk one thing, if you allow
Yeah,
me,
please.
please.
Yes, please, please.
Sir, as you said that if any infected patient came uh, in daycare or in OPD for follow-ups, and all the team, the surgery side were or can be
Yeah,
nursing side, they directly blame on the CSSD or the OR team. And
exactly.
uh, uh, sir, I research that 30% only surgeon side.
Mr. Pervez, your voice is distorted.
Sir, now my voice is clear.
Yeah, little bit.
Sir, I saw that 30% surgeon side or the nursing side, they blame the OR team or the scrub person, and the 70% our team neglect the CSSD, or they uh, uh, I think that they did not have any approach or the thinking corner to the CSSD regarding infection.
Yeah, you are right. To find out the factors of surgical site infection, which ICP, ICD department is working on. Actually, end user is not being communicated regarding the contributing factors to the end user or the contributing teams regarding actual reason behind the surgical site infections. We must report every step since from the pre-operative area, and when patient comes to back after the surgery, after the with the infection towards the OPD or IPD. It must
Yes,
be
sir. Thank you.
reported. It must be reported, and strategies would came out to make the checks on it.
Yes, sir. Sir, one point, if you allow me.
Gigi, yes.
Sir, I think we should
Mr. Pervez, we cannot hear you. Please.
Sir, my voice is clear.
Yes, please carry on your question.
Sir, Abubakar is here.
Yeah, I'm here, please.
Sir, I want to just say that I realized that need to conduct workshops or seminars to aware our surgeons team or the nursing team that if our overall team contributing there well and they did not leave any gap or malpractices, uh, uh, they can lead to the surgical site infection. But there is a wrong practice in CSSD, and the surgeon team did not know about the CSSD malpractices, and they directly blame our team or the square person.
Blame, actually, Mr. Pervez, where I got your point. Actually, blame could not do anything. Actually, reportings and the records actually do something. Okay, if CSSD have authentic practices, authentic record regarding the validation of sterilization, correct processing of sterilization, then no one can do anything. As far as I know, all the record can itself justify either it is because of the malpractice in the CSSD department or on the other end, where it could be in the OPD, in the IPD, in the nursing side. Even sometimes patient itself himself opened the dressings and came out in the OPD with the surgical site infections.
Yes, sir. Thank you so much, sir.
Thank you. Welcome. Yes, anyone else, please?
I think
Queen Esther.
everyone is done. So thank you so much, Mr. Abubakar Khan. So now
My pleasure, please.
we are going to forward to Miss Adi for the closing remarks, please. Miss Adi, please, over to you.
Sure, please.
Assalamu alaikum, sir.
Yeah,
Assalamu alaikum, sir.
Walaikum
I
assalam.
am Gulfam, a student of Janassan Medical University, Karachi, Pakistan. And I am a student of BS Operation Theatre Science Surgical Technologies, second year,
Nice.
fourth semester. Sir, please,
Yes.
I request you this material, please share on WhatsApp group. Okay.
Okay. Mr. Kulfam, it will be provided to you all on the social media sites of TORG.
Thank you, sir. Well, thank you.
Welcome.
Okay, this our presentation today's our topic is very lengthy, so we did divide it into two parts. Today we are discussing SSI surgical site infection regarding the all concerned related topics. So in the next second parts we will discuss about the disinfection and sterilization. So it's today is very insightful and fruitful topics presented by the Mr. Abubakar Khan. We are really thankful to you, and thank you everyone who is participating for the questioning and answering sessions like that. So thank you so much, and we'll meet you in a second part. Thank you so
Thank
much,
you,
everyone.
everyone. Thank
Thank you so much. That was interactive. Thank you. And very insightful as well. Thank you, everyone. Bye.
Thank you, ma'am. Thank you.
Thank
Bye-bye.
you.